are two forms of facial pain that can be helped by gamma knife treatment. The first is trigeminal neuralgia, and the second is glossopharyngeal neuralgia. So classic trigeminal neuralgia, we don't quite understand the full reasons for why it occurs. In about 50% of patients, there may be a blood vessel next to the point where the trigeminal nerve joins the brain, what we call neurovascular conflict. And as the blood vessel beats against the nerve, the hypothesis is it triggers this abnormal facial pain. In the other 50% of patients, we don't fully understand why there is this abnormality of conduction, although we think this is a result of the transition from the wrappings around the peripheral nerve as it is outside the brain. When it joins the brain, a different sort of wrapping is present. So that little junction is where we think there's a little escape of electrical information, which triggers the pain and the abnormal sensations in the face. Glossopharyngeal neuralgia is similar to trigeminal neuralgia, but the distribution is different, and it pertains to the glossopharyngeal nerve. And the glossopharyngeal nerve gives sensation at the back of the tongue, the inside and back of the throat, and along the jaw, the angle of the jaw and into the ear. Trigeminal neuralgia is far more common than glossopharyngeal neuralgia. The patients with facial pain who can benefit from gamma knife or neurosurgical treatments are those who have been through an appropriate assessment by a neurologist, and there is a firm diagnosis of typical neuralgia, trigeminal neuralgia, and that's very important. If this is not typical trigeminal neuralgia, or if it's another one of the autonomic conditions such as cluster headache, then these don't tend to respond to gamma knife. So it's very important there has been a neurologist headache review at some stage in the process to refine that diagnosis. So we make sure we're treating patients with typical trigeminal neuralgia, because those are the ones where we know we can help. So in that way, a neurologist is a very important part of the multidisciplinary process a patient goes through before having a treatment. And certainly I'd recommend all patients have a review by a neurologist, but of course they can be referred to us if you haven't already had a neurology assessment, and we can organise that as part of the workup for treatment if necessary. What's important is that the patient has firstly tried a range of medications, and pharmacological management is the preferable treatment rather than neurosurgical procedures. So we want to know that you've tried a host of medications, and either the medications are not controlling the pain, or they're causing too many adverse effects that are intrusive into your quality of life. Those are the two important indications for considering any of the brain treatments. And there are three brain treatments that we consider. One is a percutaneous procedure through the front of the face. That's sometimes called glycerol or radiofrequency rhizolysis. Another is an open procedure behind the ear. So this is open brain surgery called microvascular decompression. Tease the blood vessel away from the nerve so it's no longer pounding against it. And that provides the longest duration of reduction in severity and reduction in frequency of pain. And it's the closest to a cure that we get in trigeminal neuralgia. But many patients are not surgically suitable due to the general anesthetic requirements, or they don't have blood vessel contact to actually target for the operation. And there's a small risk of bleeding, stroke, and a small risk to life with the open head brain surgery. The third option is stereotactic radiosurgery, of which gamma knife is the one that we practice here at Queen Square. It's one of the stereotactic radiosurgeries. And this is a closed head procedure. We don't need to make any incisions in the head. We don't need to make any incisions in the skull or into the brain. And it works by applying innocuous radiation doses at different angles through the head, but where they cross over, they sum up to give a toxic dose. And we aim that to injure the nerve just as it's about to enter the brain. And the aim of that is to reduce the frequency and the severity and also the triggers of the neuralgia. The advantage is this is a closed head procedure. The procedure itself, we use a frame that we must pin to the head. So that can feel like a tight-fitting hat, and we do that under local anesthetic, and that's the only uncomfortable part of the procedure. And that's very important. It's a three-dimensional map, which we use to plot the exact location down to sub-millimeter accuracy of where we're going to give the treatment dose. We call it day case or even outpatient procedure because you don't even need to change into hospital gowns. You can go through the day from frame fitting to MRI to treatment and then home, usually in the space of a morning or into the early afternoon. Trigeminal neuralgia can occur in multiple sclerosis. There is a known link. Sometimes we can actually see on an MRI scan the changes within the brain that are occurring during the multiple sclerosis and the demyelination. So sometimes there can be a plaque in the brain stem, and that's part of the brain, if you imagine, between my fingers. So it's very deep in the brain, and that's where the facial sensation nerves enter the brain. And you can quite often see a plaque or an abnormality actually within the brain substance. So unlike the other hypotheses I was speaking about with typical trigeminal neuralgia of unknown origin, where we think the problem is as the nerve is interfacing with the brain, in multiple sclerosis, often the abnormality is seen within the brain substance itself. This means that the results from multiple sclerosis treatment in trigeminal neuralgia can be a bit more unpredictable than in the idiopathic trigeminal neuralgia, which is important. Historically, the outcomes have been a little bit hit and miss, 50-50. However, more recently, the outcomes in literature are much more favorable in reducing the frequency and severity of the trigeminal neuralgia pain. Certainly, gamma knife is something that we tend to choose in preference to the invasive treatments for multiple sclerosis, as it targets the nerve in a closed head fashion. Patient doesn't need to undergo open head surgery. It's convenient for patients who may have other disabilities from their neuralgia, such as requiring wheelchairs, etc. The practicalities of gamma knife makes things more simple, certainly in terms of recovery compared to after an operation. And the data from multiple sclerosis over the last 5 to 10 years using gamma knives become much more favorable to us using this. Number one, the ideal patient to be referred either through their general practitioner or through their neurologist is someone who's tried medications to trigeminal neuralgia and it's not been enough, or the medication are causing too many adverse effects. These are the sort of patients we can help with the next level of treatment, which is the brain procedures, gamma knife being one of them. In terms of the practicalities, probably the easiest way is to refer to Queen Square Radiotherapy Centre, where I work, and we are the trigeminal neuralgia gamma knife service for the south of England. So I think that would be the easiest port of call, but of course to my NHS or my private secretary, depending on the route of treatment. People ask whether they will be left with scars on the face or the head after surgery, but not after gamma knife radiosurgery. So it's a closed head procedure. We don't make any incisions. We don't open the skull. We don't need to go through the brain to get to our target. It's what we call incisionless surgery, one of the zero access treatments we have. What you will be left with for a couple of days are the divots on each side of the forehead where the frame has been, which is the important three-dimensional map for us to target the nerve, but they settle in the 3 to 4 days afterwards and fill out. There's a very long list of the causes of facial pain. There are benign entities such as tumors inside the head. So occasionally there can be tumors at the base of the skull that can produce disturbance of the trigeminal nerve. There can be multiple sclerosis. that can manifest with trigeminal neuralgia. So most patients undergo an MRI at some stage just to make sure these lesions are not present. In terms of the different causes of facial pain, it's quite important that a patient sees a neurologist at some stage in their journey so they can tease out the other possible diagnoses. It's quite important that we treat patients with Gamma knife with a diagnosis of typical trigeminal neuralgia or typical glossopharyngeal neuralgia. And the reason for that is if patients have atypical facial pain or they have cluster headache, which can manifest in a very similar fashion, or if they have neuropathic pain. So rather than the nasty, nasty shocks and then nothing, and then the shocks again, where they in neuropathic pain, that the pain never really goes away and there can be burning and constant discomfort, that tends not to respond to Gamma knife.